It's my turn to present a slightly different technique for achieving accurate acute corrections of deformity. And the acronym order I credit to a colleague of mine, Nick Peterson, and because we thought there was chaos, which was obviously started sometime earlier than order. We hadn't really developed the technique of order fully, but we think we have now. And so we now have an alternative, and I want to show you what it's about, how to use it, and what are the pluses and minuses as well. So this really is a presentation giving you the scope of order. You know, what is it? When can I use the technique? What are the positives and negatives? And perhaps, if I can persuade you, it's a technique that you can keep in your arsenal for solving problems. So essentially, it is a technique based on using a rail fixator. It doesn't need to be a specific make of rail fixator, but I will tell you the qualities of the rail fixator that are required to use the scope of order. The rail fixator is applied to facilitate the correction accurately, to compress the osteotomy in a manner that is greater than can be achieved with a compression nail or a compression plate, and then to facilitate substitution without interference of an internal fixation device. That's simply what order is. And who is it for? Well, it's for any patient who you think would prefer not having an external fixator on their leg after deformity correction. It is also suitable for what I call fixator negative patients. We've all seen them. You've met them, you've met their families, and you think, this patient will not cope with a fixator. So those are the fixator negative patients that this technique is suitable for. So the key things I want to credit about the technique as it evolved is we did not forsake the principles of the Ilizarov method. So keeping the biology, doing the deformity analysis as you have been taught in the last 4 days, and importantly, post-fixation, choosing the methods of stabilization that will allow early functional loading, not using a method, because one of the advantages of using an external fixator is that you can facilitate early functional loading. So if you're going to substitute internal fixation, you do not want to lose that important advantage. Now, this required some thinking because I asked myself, is it worth the hassle? Well, to explain how order works is that when I started training as an orthopedic surgeon, we were often encouraged to look at deformity as expressed in the two orthogonal views on X-ray. We see 20 degrees of angulation on this view, we see 30 degrees of angulation on this view, so we have two deformities. That's how I was taught. Then you go through the deformity analysis course and they say, that's all rubbish. You have to come back and think of one plane of deformity. It's in an oblique plane, and that's why you see it in two magnitudes on two different views. And then when it starts to get a bit more complex, they say, oh, you better stop thinking about oblique planes, just rely on the hexapod to solve it for you, because you can't think in virtual hinges. Order is going back to basics. Think about the deformity in every plane, because you solve it bit by bit in every plane. So you're going back to the future. And it's really about encouraging you to think about how you used to think, about so much deformity in the sagittal plane, so much deformity in the coronal plane, so much deformity in the axial plane, and you can resolve all those deformities at one sitting. You have total control. Now, I'm just going to digress slightly and tell you why I use a rail. The reason I use a rail is because I find it much easier to leave a lot of space for access for internal fixation, because I don't have arches or rings in the way. And so that's a big positive, and I'm going to use internal fixation as the method. Also important is I can tweak the fixator intraoperatively. Let's say I place my pins, as I view it, accurately. I do my osteotomy and I adjust my pins. Then I'd measure on my C-arm the angle that I've achieved, and I'm 4 degrees out. I do not need to go back to a software and enter parameters to tweak another 4, or do I need to go back to achieve a little bit of lengthening or a little bit more compression? I can tweak it simply as it is. And that is a big advantage, and it does speed up the process. Furthermore, I can actually do multiple levels of osteotomies on the same segment, or I can do multiple levels of osteotomies on 2 segments, femur and tibia, and position the rails so that you can have them all on at the same time. So that's also an advantage because you can control each level of osteotomy independently and adjust and tweak until the final result is what you want. So, the qualities of the fixator. First of all, you need an ability to alter angulation in one plane. In the orthogonal plane, you need the ability to alter translation. Those are the 2 qualities. And finally, you need a system that allows you to measure rotational correction. If your rail system allows you to do that, you're ready to go. I've lost. Have I finished? Yes, I've done that. Here we go. I mentioned this earlier about having a C-arm that allows you to measure angles. There are alternatives. If you don't have that luxury, you could always get the C-arm image to be printed out and get someone who's not scrubbed up to measure the angle for you. But it's obviously much easier if you can measure it using the module that comes packaged with the C-arm. So there are alternatives to measuring it. And these 2 images show you the measurements I've achieved. I'm not sure, the resolution on the projector doesn't quite show you the numbers, but the numbers and the angle are shown at the sides here. And this particular one shows I've got it perfect, and this one shows that I'm about 3 degrees out. So I've got to tweak this one a little bit more. And you can see that we also perform a mechanical axis check, like Professor Sharma showed you earlier. I tend to use a connected rod rather than a Bovie cord or a diathermy cord wire. Right, so remember I said we're going back to the future. We're thinking about the deformity in the separate orthogonal planes. And the reason is because if we did the workshop that we did earlier yesterday, if you have an oblique plane, let's say you have a coronal plane deformity as seen on the frontal view, and you place your half pins perpendicular to the anatomical axis proximal to the deformity, and you place them perpendicular to the axis distal to the deformity, and let us then assume that you have a sagittal plane deformity as well, and you place those pins in the clamp parallel to the anatomical axis in the orthogonal view, you are dealing with that oblique plane deformity. That's exactly what you're doing. You're going back to what you originally looked at, which is the dimensions and the characteristics of the deformity in the 2 views, and you're putting it together in the 2 ways. So when you actually cut the bone and make the frontal plane pins parallel, and you make the lateral plane pins clamps in line, you resolve your oblique plane deformity. Does it work? Well, let's have a look. Here is one. This is an oblique plane deformity. It is almost similar to one of the previous cases shown that was treated with an intramedullary nail and a hexapod. But using a different technique, you have your half pins perpendicular proximal, half pins perpendicular to the anatomical axis distal, and you would want to place your half pins parallel to the sagittal axis in the lateral view. And again, because I'm planning to use an intramedullary nail, I will position my pins posterior to the trajectory of the nail. So this is the intraoperative view with an intraoperative check of the final angle that you achieve. Once you've done that, you compress the osteotomy with the external fixator. That's a quality that rail fixators will allow you to do. Of course, you can do it with a hexapod too, but you'll have to program that in the correction that you achieve. And while that compression is being maintained, you perform your reaming and obviously the introduction of your intramedullary nail. Can I then tell you that this deformity in the oblique plane measured 42 degrees. This was an acute correction of 42 degrees of the distal femur with resolution of the deformity and union after intramedullary nailing. So I've shown you an example that oblique plane deformities can be corrected with a rail. What about rotation? And what about rotation and angulation? Can we do that, or do we have to go back to a hexapod? Remember I said, think of the components. So let's say we have this lad who's had a malunited femoral fracture. He is 35 degrees malrotated. He's so rotated that his patella is sitting on the lateral edge of his femur. And this is as a consequence of a nailing. And the patella is subluxing, and that is purely because he has a malrotation as well as a coronal plane deformity. So do we have to use a hexapod? No. How do we solve this? You start first by using derotation templates. That's one of the qualities of the rail system that you need to have. And having derotation arcs, you can dial in precisely the amount of derotation you want. And here we've dialed in 35 degrees of derotation. Notice that I'm placing the rail anteriorly. This rail is in the anterior position of the femur. I perform the osteotomy based on my preoperative planning as to where I want to achieve the correction of the angulation and derotation. I derotate first, solve that rotational abnormality, and now I put a second rail in the coronal plane away from the trajectory of a nail. And I can now focus on the coronal plane or even oblique plane deformity like I did before. What's the caveat? When you've achieved the correction, you take off the anterior rail because you've already achieved the derotation and just leave the coronal plane rail down, and that allows you to achieve the correction over an intramedullary nail. And you'll notice, because the rail is posterior to the intramedullary nail, you can lock proximally and distally while the rail fixator is still on. One of the common things that's often asked about acute correction, whether you do it by rail or hexapod, is about the nerves and the nerves at risk. And the most common place that you'd think of is in the proximal tibia. And there are three things in the proximal tibia, three corrections that would jeopardize the nerve to a neuropraxia. And these would be external rotation to internal rotation, valgus to varus, and flexion to extension, okay? If you have a flexion deformity and you suddenly extend the tibia, that would stretch the nerve, similar with valgus to varus and external to internal rotation. So in these cases, I would suggest it's a mandatory to consider a common perineal nerve neurolysis. And you would have seen that in your cadaveric workshop, and there's a video on that as well. The reason is I do not know what is the safe limit to perform an acute correction in the proximal tibia for these deformities. Some people say it's 10 degrees, but I've seen palsies with even 10 degrees, and I've seen no palsies with 15 degrees. So the safest thing is to perform a neurolysis. So here's a clinical example of such a case. This particular patient, as you can see, has a valgus deformity with a cora that will lie in the proximal tibia. The left side's okay, the right side not. And here is the cora position. So it's in the junction of the upper third of the tibia and the middle third of the tibia. Why not external fixation? This is an adolescent with autism. So this is a person who's fixator negative. So this would be a good indication to consider external fixator assisted correction. As I mentioned, it would be mandatory to consider a common peritoneal nerve neurolysis. And you've seen that there are two techniques. You've got the Paley technique, which is from proximal to distal. We've got the technique we've shown you here, where we try to find the nerve distally first and then lift off the origin of peroneus longus, so you deroof that completely and trace the deep peroneal nerve as it enters the anterior compartment. So here we have the series of C-arm views showing the correction. You have the perpendicular pins proximally, and you have the perpendicular pins distally. And you have that Rancho cube helping me to dial in. And that's one of the great things I like about coming to these courses. I learn as much as I deliver, and learning that I should be calling this a barrel instead of a dome, I'm going to take that home. Because that's right, it's more of a barrel than a dome. It's never a dome. So this barrel osteotomy, correction, and then compression, that makes the stability, the shared stability between the osteotomy and the implant such that you can use a standard trauma implant. That is, the compression makes a big difference to the shared stability between the implant and the osteotomy site. So here you have basically a lateral proximal tibial plate that's used. That's the correction, and that's the healed and final result. Sorry, just to give you some evidence that the axis has actually improved. Now, again, to acknowledge the people who did the research, Nick Peterson and Ahmad Al-Sheikh, we've done over 100 cases using order. This is a small subset because the reason I've chosen this cohort is because I've got a comparative cohort that was published of another series. So these are tibias that were treated using order, and the first 23, 21 in the tibia, 21 by plates and 2 by intramedullary nails. And what I'm chosen to compare, why I've picked this subset out from the 100 or so that we've done, is simply because the other group is treated with a hexapod gradually. Because the common criticism of acute correction is it's not as accurate as gradual correction. And if you look at the data that you can see in the tables, there is virtually no difference between what we've achieved and what the hexapod group have achieved with gradual correction. And the reason is very simple. When you do gradual correction by a hexapod, you have to take X-rays, whether they're standing or standard X-rays, and you as a clinician have to decide, that is it, I've got it corrected. You make that decision, I've got it corrected. That same process happens with order, but happens in theater. You tweak, you adjust, you remeasure until you say, that's it, I've got it corrected. And that is why there's no difference, because the final process of deciding it's good enough is you, not the hexapod, not the rail. So that's why there's no difference between the quality of correction either way. We have had some complications in this group, including one nerve palsy that recovered at 6 months. And the reason we had that was, as I said, I do a mandatory neurolysis. And in this particular case, I remembered quite clearly, after having done the neurolysis, I said to my registrar at the time, who was actually one of the co-authors, Nick Peterson, I said, this nerve is still tight. And normally when I do a neurolysis, I can actually see the nerve flop and quite clearly around the neck of the fibula. And I said, this nerve is still tight. And lo and behold, this adolescent had a common peroneal nerve palsy after the correction, which he recovered at 6 months. So it's interesting. That might explain why, in some individuals, a correction as small as 10 degrees will still give you a palsy, because the nerve, as it progresses around the neck of the fibula through the muscle, is tethered to various extents. Can you do it in the femur and tibia? Well, that's one of the big advantages of using order. So as I mentioned, we always check our angles and we check our axis, and we use a threaded rod connected by sockets to do that measurement. But let's look at this case. This is a patient with a congenital short femur that underwent lots of lengthening as a child, so much so that this was in the early days when people didn't really understand the soft tissue problems of lengthening in a congenital short femur. So he had a dislocated hip as a teenager while lengthening. They tried to put it back. So he's got not only deformity from previous regenerate, but he's got a hip that's stiff and slightly sublux, although not painful, and he's actually a practicing clinician. So he comes to me and says he walks with a poor gait. He doesn't want any lengthening. Can you improve the ability of his walk? Can you improve his gait? So let's analyze the deformity. And if we analyze the deformity, it says 3 osteotomies to try and neutralize and improve his mechanical axis. 1 in the proximal, 1 in the distal femur, 1 in the proximal tibia. Now, those who are very skilled with chaos and hexapods might be able to do this. I think it would be very difficult to do the top and bottom and just allow the middle to sit down. But to do the tibia as well, you'd struggle to fit all the rings. You might be able to do 1 ring at a time, then the next set of rings, and then the next set of rings. 3 separate hexapods in sequence, and that's possible to do it. But one of the advantages of using rails is you can put them all at the same time and do all the osteotomies and stop there and check and tweak each level until your final mechanical axis is right. So you don't commit to any internal fixation until the 3 levels are correct and compressed. And only then you say, I'm good, let's do the internal fixation. And that's exactly what we did here. And if you think ahead and position your rails, you don't obstruct your internal fixation. We put the rail anteriorly at the top because we were planning to use a lateral plate. We put the second fixator laterally because we're going to use a small medial plate, and then once we take the rail off, put a second lateral plate. And similarly, in the tibia, we were planning to put a lateral plate. So this was the post-correction result with a neutral axis, all done at the same time using a series of rail fixators. So I'm going to leave you with some take-home messages. It is an accurate way, as accurate as gradual corrections for the right cases to perform deformity work. You can use standard trauma implants. The caveat, and I don't want to contradict Professor Sharma, the caveat is we're achieving high compression at the osteotomy. So there's shared stability between a standard implant and the actual osteotomy site. And finally, if you're going to take this on, you must preoperative plan and you must do simulation of your correction on your software before you undertake the procedure. So you can think ahead about where to place your rails, where to do your osteotomies, and how to insert your internal fixation implants. Good planning is really necessary. And if you get it right, it's the perfect example of getting it right first time. And it's one technique to add into your arsenal for solving deformities. So in the whole thing that you've seen in this course and the different techniques you've learned in this course, you've got a choice. You've got a choice between chaos and you've got a choice with order. Thank you.